Good morning, team. I am Ju Hui-ji, lead clinician of Crossroad Community Clinic. Today, we will go through psychological assessment in counseling, two, not labels. Crossroad Community Clinic serve a diverse and complex population, such as high school students experiencing career anxiety, refugee managing trauma histories, and corporate professionals facing burnout. Recently, we have received several misdiagnosed complaints. Upon review, a common theme emerged: some junior counselors rely too heavily on the test score without fully considering the whole person. Today's training is about correcting that. Psychological assessments are powerful tools, but they carry significant ethical weight. A number of skills can influence treatment decisions, client identity, institutional reports, and even insurance claims. Our responsibility is not just to administer the test correctly, is to interpret them wisely. The core message for today's session is a test score is one piece of much larger human puzzles. The contents today will be psychological testing versus psychological assessment, part A 2, part B critical discussion, and a final message for everyone. Before we discuss specific tool, we must clarify terminologies. Psychological tests refer to the use of standardized instruments designed to measure specific psychological constructs. Those instruments produce quantitative score and are typically norm-reference or criterion reference. Psychological assessment is broader. It is an integrative clinical process that combines test results, interview, behavioral observation, case history, and contextual factors to form a comprehensive understanding of the client. The test measure assessment interpreting when misdiagnosis occurs is because testing was mistaken for assessment. For the assessment matter, provide constructed information for clients, guide interventions, monitor client process over time, support ethical and evidence-based practice. Part 3, tools. A tool that we commonly use at the crossroad is the Beck Anxiety Inventory (BAI), developed by Aaron T. Beck and colleagues in 1988. The BAI measures the severity of anxiety symptoms, particularly focused on psychological and cognitive symptoms of anxiety. One of its strengths is its ability to differentiate anxiety from depressive symptomologies. The BAI is a 21 items of self-report inventory. Clients rate how much they are bothered with each symptom over the past week using a 4-point Likert scale, ranging from 0 to 3. Total score range will be from 0 to 63 with established cutoff indications minimals, mild, moderate, or severe anxiety. The tool has a strong internal consistency and solid symmetry validations. However, understanding mechanism is not enough. The key question is how does this score guide interventions? If a client score in the moderate to severe range, anxiety management must become a treatment prioritized. For examples, high psychological skills such as implement breathing retainings and grounding technique. Evaluate connective items indicate distorting patterns, which point us toward connective restructuring interventions. The BAI aligns closely with cognitive behavioral therapy, originated by Beck in 1976. CBT conceptualized anxiety has been maintained by catastrophic thinking and avoidant behaviors. The assessment, therefore, informs both of the treatment focus and the therapy model selections. But remember, refugees clients score high on somatic items may be expressed trauma-related hyperarousal. Context is critical. The second commonly used tool in our clinic is the patient's clinic health questionnaire 9 (PHQ), developed by Kirk Carkins. The PHQ-9 measures depressive symptoms severely based on DES and diagnosed criteria. The PHQ-9 is a 9-item self-report scale using a 4-point Likert format from 0 to 3. Score range will be from 0 to 27, indicating minimals to several depressions. Critically, 9 items screams for suicidal ideations. These single items carry immense ethical responsibility. If a client score in the moderate severals to all several range, and in particular if item 9 is endorsed, immediate suicide risk assessment is required. This means conducting a structured risk assessment, determine interim plans and means, implementing safety planning procedures, considering psychiatric reference if necessary. For mild to moderate score, behavioral activations and cognitive restructuring may be appropriate. The PHQ-9 aligned to back cognitive theory of depressions, particularly the cognitive threats of negative belief about their self, the world, and the futures. Again, a test scores gut but does not dictate treatments. A corporate professional scoring high during a peak workload may be experiencing situation burnout rather than a major depressive disorder. I repeat again, assessment must be considered context. Both BAI and PHQ are appropriate for our clinics, briefly and efficiency in a high-traffic environments. Psychometrically validated, useful for baseline measurements and process monitoring. However, no tool replaces clinical judgment. As Kaplan emphasized, ethical assessment requires integrations of multi-data source. For Part B, will be critical discussions. Limitations 1. Cultural and linguistic bias. Many standardized tools are normed on Western populations. Cultural groups may express distress differently. Refugees clients, for example, may somatic trauma symptoms without cultural competencies. We risk mispretensions. Use cultural sensitive interventions. Supplement standardized measure with narrow explorations. Limitation 2. Reductionisms. Assessment reduce complex human experience to numerous values, while quantifications increase reliability and increase oversimplifications. Impact at crossroads. A teenage become 22 years old on the PHQ-9 instead of raving or overwhelming individuals. Always integrate strange and protective factor in feedback sections. Limitation 3. Snapshot effect. Assessment capture a single moment in a time. Mood fluctuate, stress fluctuate, circumference change. A student during an exam week may score severe anxiety because stabilizing afterwards. Monitor trends across time rather than relying on a single administration. Limitation 4. Self-report bias. Client may underreport due to sigma or overreport due to distress validation needs. The impact is risk of missing suicidality or misjudging severity. The strategy is will be build rapport, cross-validate with clinical interviews and behavioral observations. Limitations 5. Ethical labelings. Diagnosed labeling can infuse identity formattings and reinforce stigma. Client may internalize "I am depressed" rather than "I am experiencing depressive symptoms." The strategy will be use calibrate language, frame result as current presenting patients, not fixed identity. For the senior clinician's principles, never diagnose from one test, always integrate multi-data resource, state limitations, prioritize safety over scoring, protect client dynamics in feedback. A final message for everyone. Psychological assessments are powerful. They guide treatment plannings, they enhance objective, they improve outcome trackings. But they are not identity, they are not verdicts. They are not replaced for with clinical wisdom. At Crossroad Community Clinics, we do not treat score, we treat peoples. And our ethical responsibility is to ensure that every test score is interpreted within the full human story. Lastly, thank you everyone for your time.